Hi there, I'm Dr. Jim Gould of the St. Louis Sinus Center. Thank you for joining us today for our live case supported by Entellus. We hope that you'll find this case informative and interesting and educational, and feel free to ask questions throughout, and we'll get back to you with answers as time permits. So our live case patient, Dan, is a 34-year-old male who's had chronic sinusitis for years. He's had symptoms of facial pain, facial pressure, congestion, difficulty with headaches, postnasal drip, sore throats. He's really suffered over and over and over and has had multiple antibiotics, I think 3 to 4 Z-Paks, a 21-day course of Levaquin, more recently another 14-day course of Levaquin, nasal steroids, saline, antihistamines.
I don't think I'm very fun to be around while I have these severe sinus infections. Even after the sinus infection goes away, my fatigue levels are still there. So I feel like almost like a burden on the family if I'm too tired to do something. You know, I want to be the best father. I want to be the best husband I can be. It's almost become a part of me, and I want it to be something that's part of the past. Just treating the symptoms is what I feel like I always do. And I'm looking for that permanent fix.
He's really tried everything and just cannot get any relief. He's got a sinus CT scan that showed significant sinusitis, and we'll show you that in a minute. So it's really important to have the CT scan with you at the time of the procedure. We have this mini CAT CT scanner on site, so it's really easy for us to look at the films and actually scroll through the images at very fine cuts as we're doing the case. So it's really nice to have that access, and it's very important to your success that you keep CT films on site and available during the case. We're going to take a look here at Dan's CT. You can see that his nasal septum here is midline. As we move more posteriorly on the coronal images, you can start to pick up the frontal sinus there. And if we look at the maxillary sinuses, which are coming into view now, you can see that there's substantial mucosal membrane thickening, several millimeters on both sides. We're also picking up some anterior ethmoidal disease that's moving into the frontal recess or the frontal ostium. And as I continue to move more posteriorly, you can see that there's thickening of mucosa and also sinusitis here at the frontal sinus ostium and frontal sinus recess areas. If we move back to the middle meatus and infundibular region, you can see that Dan has complete occlusion of both the right and the left infundibular space. Middle turbinates look pretty good. Septum is still pretty midline here. And then again, more of this ethmoidal opacification as we move posteriorly. As I keep going more posterior, we start seeing additional patchy opacification of the ethmoid sinuses. And as we get into the sphenoid sinus area here, you can see that there's substantial mucosal membrane thickening as well. Last point is just to move back to the cuts of the inferior turbinates here and here, substantially hypertrophic, so we're going to be reducing those at today's procedure. One thing I want to point out here too, you can see that Dan has this really, really small left frontal cell, which is here, and I didn't mention that previously, but Dan has this really small left frontal sinus cell, but it certainly is opacified inferiorly as we pick up the frontal recess area and the frontal sinus ostium. So there's substantial disease in that very hypoplastic frontal cell on the left, but you can see as we scroll through, the pathway is going to be right through here into accessing for our balloon dilation. So we'll need to look out for that left side and see how difficult the access is going to be. And I'm guessing it's going to be a little bit challenging, and we'll see what the effects of the sinus being hypoplastic there are on our transillumination on the forehead with the LED light fiber. And our treatment plan for Dan today is to do multi-sinus dilation, and that would be dilation of the frontal, sphenoid, and maxillary sinuses. We're also going to do bilateral inferior turbinate submucosal resection, and we'll use a 2 millimeter microdebrider blade for that. And we're probably going to also do anterior and possibly posterior ethmoidectomy, given some patchy opacification that we saw in the sinus CT scan. So my anesthesia protocol for the typical office balloon sinus dilation patient is as follows. Oral sedatives, including Valium and Vicodin. If they have sensitivity to narcotics, we will substitute Phenergan and Tylenol instead of Vicodin, but most patients get Vicodin and Valium. We give them doses of those approximately 90 minutes before they come in, and then again they get redosed 30 minutes before they come in, and then we assess them when they get here to see if they need more. We have them bring their little prescription bottles with them, so if they need more we can give them more, and we just assess them when they get here to make sure they're feeling relaxed and comfortable. So once we've got that part done, we take the patient back to the room. Our nurse sprays them down with topical 4% lidocaine and Afrin. We find that it's important to spray with Afrin before you do anything else so that you get a nice vasoconstriction. And then after that's done, we typically lay the patient back and we put cottonoids in the nose that are soaked in 1 to 1,000 adrenaline and 4% topical lidocaine. And actually, my nurse specialist places those endoscopically for me, and she's a real expert at doing that, and she's trained to do it, and she does it endoscopically with a monitor. She places those in very specific locations. We typically place 1 cottonoid in the middle meatus, 1 in the sphenoethmoid recess, 1 along the anterior face of the middle turbinate, and then 1 along the inferior turbinate. Once we've let those sit for about 10 to 15 minutes, I come in, we pull those cottonoids out, and we start doing very focal specific injections. We really emphasize the use of small gauge needles. We use a 27 gauge needle and small syringes so that you don't have to generate a lot of hydrostatic force and pushing on the syringe, which can sometimes make your hand shake or make your injection less precise. So small syringe, small gauge needle, 27 gauge needle, and we inject very specific locations every single time. It's very reproducible from patient to patient. We inject the root of the middle turbinate, the uncinate process, the anterior aspect of the middle turbinate, the sphenoethmoid recess area, and the posterior nasal septum if we're going to do sphenoid dilation work. And then we also inject always the Sphenopalatine area transnasally, typically going through the middle meatus. Some people don't quite understand where that is exactly. So to clarify, where the middle turbinate turns laterally and posteriorly near the nasopharynx is right where that Sphenopalatine block is needed. So you inject that. For that, we use a long 27 gauge spinal needle that's about 3.5 inches, and that kind of facilitates the process. Once we do those injections and have done that topical and gotten the oral sedation protocol down, you really can do just unbelievable things with the nasal cavity. You can do ethmoid work, polypectomy, completely painlessly and comfortably for patients. So if you follow that protocol, it's very reproducible from patient to patient with regard to their comfort level. We've gone over the patient history, the sinus CT scan, and the treatment plan. Now we're going to move to the live case. Welcome everyone to our live case. We welcome you to the St. Louis Sinus Center, and thanks for tuning in tonight. We've got a great case lined up for you to showcase the new Entellus XprESS Ultra device. I want to thank everybody who's worked so hard to put this together. Entellus just worked so hard to make this production really awesome. I also want to thank Dan, our patient here, and thanks Dan, appreciate it for doing this, and you looked great on film a little bit ago. I also want to thank Megan, my nurse here, and she's with us today, and I have Dawn here over on this side, and she could step up real quick and say hi. And also want to thank Eric from Carl Stores, who provided the telescopes and the HD monitor for us. So we're going to go ahead and get going, and we'll talk a little bit about the advantages of the XprESS Ultra device as we're working. And I'm first going to go ahead and get started, since you've seen some of the high points of the anesthesia protocol that we use. I'll talk about that for just a second. Dan has already had some oral sedation with Valium and Vicodin, and he's feeling really relaxed, but he's not overly sedated at all. He's also had some topical 4% lidocaine spray and Afrin. We've also placed some neurosurgical cottonoid pledgets in the nose with 1 to 1,000 adrenaline on them, as well as also a little bit of 4% topical lidocaine. And we've done a few little pre-injections just to facilitate the flow of today's live case. So you may see where we've done some injection points, but I am going to specifically go ahead and re-inject and show you those key injection points to make sure that everyone understands those, and just to make sure you know how to make sure the patient is very comfortable in the office. So we're going to go ahead and get going, and we're going to first take a look in the nose. And this will be interactive, so if there are questions from those that are viewing, we will be able to field some questions intermittently, so we're going to take a look. So here's the left side of the nose, and you can see the middle turbinate. We have just a little bit of submucosal hematoma there from just doing a few little injections, and you see the inferior turbinate there. Superior turbinate is way back up there. And I'm going to go ahead and take a freer elevator and just kind of expose the middle meatus slightly, and then we'll get going with the injections. So here's our middle meatus region. You can see the ethmoid bulla here. You can see the uncinate process there. You can also see that there's some active, slightly purulent or mucoid fluid draining out of the ostium or infundibular region, and it looks like there's a little accessory ostium back there as well. I'm going to go ahead now and just demonstrate the injections and show you how those all work. We really feel it's important to do the injections in the office for awake, sedated patients. And bear with me just a second here. Can you tip your chin up a little bit? Okay, that's good. So first injection is at the root of the middle turbinate here. And we just inject maybe about a half a cc or so until you see a nice little blanch. And then I usually will inject a little bit onto the uncinate process, which is here, a little bit of blood there because we've done some pre-injecting, and then I'll usually inject here at the anterior face of the middle turbinate. And next, I usually will come back and inject the inferior turbinate here, just because you're usually moving all around the inferior turbinate while you're working, and it's good to have that numb, even if you're not going to do a procedure with the inferior turbinate, just to make sure that you're not causing any unnecessary discomfort. So I'm using a 27 gauge needle that's 1.5 inches long, and also a 3 cc syringe. Now I'm going to switch over to a longer needle, which is a spinal needle, which is about 3.5 inches, and that's also a 27 gauge. And I typically use this to do an injection in the sphenoethmoid recess here. And here's the sphenoethmoid recess back in this area. I'm going to do a little injection posteriorly along the septum, just like this. You'll see a little blanching going on there and a little mucosal swelling and local tissue tumescence. I'm going to also inject the superior turbinate here. We find that it's easy to do that. And if you inject the superior turbinate a little bit, it really eliminates just about every bit of discomfort in the sphenoethmoid recess region. Next, we usually like to go ahead and displace the middle turbinate a little bit to expose the Sphenopalatine region, and let me just show you how we do that. So I'm going to just move the middle turbinate over just a little bit. You'll notice this middle turbinate kind of trends laterally and wants to kind of flop back out laterally. It's a little bit rigid, and so I'm going to go ahead and take the freer and just kind of push it over medially pretty firmly. And then you can see the basal lamella here as it turns laterally. One thing you can do is just gently fracture the basal lamella just a little bit, just slightly, to release some of the tension and the lateral spring of the middle turbinate. And if you do that, it'll help the turbinate stabilize in a more medial position, and it just helps if you're really struggling with a tight middle meatus space, and that's just an important point. So now I'm going to use the long local injector again, and we're going to go back through the middle meatus. I usually do the Sphenopalatine injection on every single case I do, even if it's just a simple maxillary dilation, just because it really aids in comfort for the patient. So here we are going through the middle meatus. We're just below the ethmoid bulla, and we're headed back to the Sphenopalatine region right back here. I'm going to go ahead and inject. And this is the region where the middle turbinate just turns laterally, and inserts at the lateral nasal sidewall. And so if you just inject this general region, you don't have to be super precise, but you just want to get that region blanched. That's going to give amazing anesthesia and allow you to pull off multi-sinus dilation in the office with great comfort, as well as more advanced procedures like anterior or total ethmoidectomy. Okay, so we've gotten the injections done. We're going to go ahead and take a look on the other side now. We have done some pre-injecting over here. I'll note that there is, freer please, there is a quite, not an insignificant septal deviation, and it's important to note that most septal deviations don't necessarily need to be fixed, and you can work around them very easily. So here's a septum. It's actually really somewhat deviated, but it's not going to prevent us from getting a successful dilation here. But it's important to note that. If you look in through the middle meatus here, we can start to see the key anatomic structures. Here's the middle turbinate, here's the ethmoid bulla, and here's the uncinate process. This little area through here is called the hiatus semilunaris, and that leads into the infundibular space, which is the key space for maxillary sinus dilation. And we're also, of note, dilating the ethmoid infundibulum, which also aids in clearance of ethmoid sinusitis. So I'm going to go ahead and do the injections briefly over here. We've already done some pre-injecting. And you'll notice I pull the telescope back to the nasal vestibule before I insert the needle, so we make sure that we don't inadvertently poke the nasal vestibular skin, which is really uncomfortable. And we're going to go ahead and do an injection here at the root of the middle turbinate.
Dr. Gould, what is the amount you typically place per injection site?
You know, it's really only about a quarter of a cc. It's very low volume. And I'm injecting the inferior turbinate now. So very low volume injections, you don't need a whole lot. I'm going to the long injector now, and we're going to go ahead and again bring the telescope out so that you see the nasal vestibule plainly, so that you don't inadvertently inject the nasal vestibular skin or poke that area. And then we're going to go back here and look at the Sphenopalatine region right here at the root of the middle turbinate, and we're going to get right in here with the telescope and do this little injection right in that space. And you're going to do that till you see a nice blanch. There is a little local that leaks into the throat, so you need to warn patients about that they might taste it. We don't get a lot of leakage, especially with the small gauge needles, and that's why I would emphasize the 27 gauge needle as being very important, because you get less leakage of local and subsequently less throat irritation for patients.
What is the size of scope that you typically use for these types of
cases? Yeah,
cases?
so these scopes are really great. These are from Karl Storz. They're 3 millimeter diameter, and they're 14 millimeters, 14 millimeter or centimeters, 14 centimeters in length, 3 millimeter diameter. They're really great because you get into tight spaces, and it's really nice to have a shorter working length on the telescope, and it just seems a lot easier to manipulate this size of scope in the office. But they give you this great visual field, the same field that you get with a 4 millimeter large adult scope. So we're going to do one more injection here. I'm going to take the freer elevator just to expose the sphenoethmoid recess, and you can see that we're working around a deviated septum, and that's not going to cause us to fret. And we're going to get to the middle turbinate and displace it over just a little bit medially here like this, laterally just like this, and expose that sphenoethmoid recess. I can start to see areas that are key. I can see the sphenoid ostium right there ahead of us, and then I can see the superior turbinate just laterally there. Megan can point to the screen if you can see that where the superior turbinate is right there. So this is the key area, and we're going to go ahead and do an injection back there now. And again, just bringing the telescope out so we can see the nasal vestibule clearly. And can I get a little defog perhaps? No, I'm okay actually. And so here's that injection along this posterior aspect of the septum in the sphenoethmoid recess. And then if we wanted to, we could inject the superior turbinate as well, but we're not going to need to do that. So those are the key injection points. Really important to follow that protocol for good success. We just find that we have reliable patient comfort, great patient experiences when we take time to spray topical anesthetic, place cottonoids, and also do all of these injections in a slow, precise fashion. So next, we're just going to go ahead and take the Path Assist Seeker. This is the Entellus Path Assist Frontal Seeker. It's a lighted device, and it is autoclavable. It's a 78-degree bend. We use this almost every case just because it really facilitates tactile feedback and it helps you define the pathway into the frontal sinus. So we rarely skip using this. We might skip using it on the contralateral side because of some complex anatomy that we've identified after a very, very detailed review of the CT scan, which you all got to see in the introduction. So here we go with the 1.5 millimeter ball tip, 78-degree angled Entellus Path Assist Frontal Seeker. And we're going to just insert into the middle meatus, and here I am in the frontal recess region, right at the superior aspect of the infundibulum, right? And they were right in front of the ethmoid bulla there, and I'm going to just take the device and slightly tilt it out just a little bit laterally. And here we are lateral. And I'm going to insert it. It feels like it's going in pretty easily, which is good to see. And we've got some nice illumination on the forehead. I think you guys can see that probably with the camera angle. But you can see there's a little bit of really nice excursion of light, meaning the light traverses back and forth across the forehead. This is a really key defining technique for making sure that you're actually in the natural ostium of the frontal sinus and not a false pathway. So we like to see the excursion of light back and forth from side to side, and the XprESS Path Assist lighted seeker really helps us do that. And one thing I'll just add is that you know, Entellus has this whole portfolio of instruments now called the XprESS family, and the devices have continued to get more and more refined over time. Much sleeker, more slimline, add of an LED light fiber that has its own battery pack that's disposable. The engineers at Entellus have really thought of every single detail, and just when I think that it's as good as it could get, they come back and bring out another device that's even better. So just want to say hats off to Dennis and John and all the guys, Tim there at Entellus. So we're actually going to go ahead and start on the right side. This is the actual Ultra XprESS or XprESS Ultra device. You can see that it's nicely tapered. I don't know how well you can see that on the camera there, but here's the device, and we can easily slide the balloon forward. Megan can do a test inflation just to show you what the balloon looks like. This is a 6 millimeter diameter balloon, 20 millimeter length, which is clearly long enough to dilate any complex frontal sinus and deflate. So really nice tapered device. The tip is, the ball tip is actually 1.5 centimeters, and the hypotube is now 1 millimeter in diameter, which is just amazing because it's a great working channel. You can work through this device at 1 millimeter, which is just, it just kind of blows my mind that you can do that. So we can carry the light through the hypotube channel, and we can also suction and irrigate through it, and it's just a really amazing tool. And you know, this is actually so narrow and tapered now, it's really almost like a wire, and but it provides really good tactile feedback, which we find as being a very important key element to good success and precision placement of the balloon. Okay, so we're going to go ahead and take a look on this right side and insert our XprESS Ultra into the middle meatus region, and here we are. You can see the 1 centimeter black shaft marker band there coming into view, and I am working around this deviated septum, so it's ever so slightly challenging, but no big deal. And there's a 1 centimeter shaft marker band. I'm going to go ahead and tilt the device just a little bit laterally. I refer to this as the lateral tilt maneuver. It seems like about 90% of the time the ostium is off midline to the lateral direction about 10 degrees, 15 degrees. So there's our 1 centimeter shaft marker band and our 2 centimeter shaft marker band, so we're really fully inserted. So that's one confirming technique. If you have the 2 centimeter shaft marker band buried behind the uncinate process, you really feel pretty good that you're in. But next I'm going to have Megan advance the light fiber in, and you can see that we had a really nice insertion of the light fiber. And was it easy to advance it in?
Very.
So very easy insertion and full insertion of the light fiber distally beyond the ball tip. We feel that's a really important technique to additionally confirm that you're not in a type 3 frontal cell, etc. Can you see that? Oh yeah. Can you see how that's fully inserted? Okay. And Megan can pull that back a little bit. Okay, but you can put it all the way back in now. Okay, so that's fully inserted. You see really great focal pinpoint illumination on the forehead. I don't know if you guys can see it better with my telescope or if you can see it better if I pull away and just look with the overhead. But we see great focal illumination, and now we can see this excursion of light, which is really just phenomenal. Advance in just a tiny bit more. It is, okay. And really great excursion of light demonstrating that we're in the natural ostium, distal actually to the natural ostium. So now I'm just going to simply advance the balloon in with a gentle technique here with the thumb, and we're fully inserted. I'm going to go ahead and inflate the balloon now, Dan. And here we go. You're probably going to hear a little crackling and popping. And deflate. And then I usually will go ahead and advance the device in a little bit further, like this, and inflate again. And we'll hold the inflation up for about 5 to 10 seconds so you get to that full 12 atmospheres of pressure, so you get a good solid remodeling of the natural ostium. Let's deflate. Okay, and then I'm going to pull back and I'm going to inflate one more time. You probably don't need to inflate 3 times, it's just what I do. And you can see that nice deflection of the uncinate process there at the superior aspect of the infundibulum, which merges with the frontal recess space. Let's deflate. So now that we've done our 3 inflations in the right frontal sinus, I'm going to go ahead and pull the balloon back. And Megan's going to just kind of stabilize the light fiber. I'm going to have you actually advance it, pull it back a little bit. Okay? Actually advance it forward a little bit. Okay, so now you can see this great excursion. Look how much the excursion has opened up. Can you guys see that on your monitor? You see that on the monitor? Yep. The excursion is just dramatic, and it's that freedom of motion and the increase in excursion that allows you to tell that you've really completely remodeled and dilated that frontal sinus ostium adequately. You certainly don't have to go up and look at the frontal sinus ostium, but you certainly can. I'm going to have you pull the light fiber back now. So if there's any question that you have or haven't successfully dilated the natural ostium, you can go ahead and take a look. And I'm going to go ahead and do that now. How was that? Was it okay? Did you have much discomfort?
Little to no discomfort throughout the entire procedure. So.
Awesome. Did you hear a little popping or crackling?
Yeah, but it was just very minimal.
Okay,
yeah.
Excellent. So good job. So
it's not even worth mentioning.
Okay, excellent. So I'm going to just really quickly see if we can see our dilation. We know that we've dilated the frontal ostium, but if we can take a quick peek with the 45-degree telescope. This is another one of those 3mm scopes, and we're just going to look up there and see if we can see it. And if we can, it's just nice to be able to take a peek at our dilation. And there you go, right there. There's the dilation site, nice and open. You can see the posterior table of the frontal sinus up there. And if we did some suctioning, you could see that a lot better. But in the interest of time, I'm just going to show that and show you that that's the dilation site, and it's wide open. Okay, so Dan tolerated that great. That was a classic frontal dilation, great confirmation. Everything was just perfect. And you don't always have such great anatomy and ease of access. So we're going to look on the contralateral side. If you noted on the CT scan preoperatively, there was a type 2 frontal cell that was opacified. That cell is making the access on the left side. I'm sure it's going to be more difficult than normal. We're going to go ahead and take our Path Assist device first and just see if we can use that on this left side. But sometimes an Agranazzi cell or a type 2 frontal cell or type 3 cell can be difficult to work around. And we have some techniques to talk about that that help us get around that problem. You can still see that our middle turbinate is adequately medialized from our little maneuver on the basal lamella back there. I'm going to go ahead and just probe here gently with the path assist seeker, and I'm kind of meeting some resistance there. We're probably just hitting that Agar-Nazi cell there, and there we kind of get in, and let's see, got a little bit of illumination and a little bit of excursion there. So I think our type 2 frontal cell is really impairing some of the illumination that we would normally see. And of course, as bright as this path assist device is, the LED light fiber on the Ultra is much brighter, so we'll be able to see that better in just a second.
Dr. Gould, I noticed one thing you did is drop your hand down towards the patient's chest. Is that something you routinely do?
Yeah, I usually will do that to change the angle. So instead of having to bend the device or change the bend, you can just move your hand up and down to change the angle. And so that really helps facilitate easy access into the sinus. Okay, so we're going to go ahead and pursue this pathway with the Ultra device. And again, we're going to be tilted a little bit laterally. And here's the 1 centimeter shaft marker band. So that's going out of view, and 2 centimeters. And I'm meeting some resistance right there, so I'm going to reposition a little more laterally and just see if we can get, oh, there we go, it just popped in. You felt it kind of pop through the ostium. And now we have a full insertion of the light fiber, nearly full insertion. Now, we're noting here that we have good illumination on the forehead, but the actual excursion is not quite as good. I really think the complexity of this left frontal sinus is unusual, and that the actual Agar-Nazi cell and the type 2 frontal cell are preventing some of the illumination to be from being seen from the light fiber because they're sitting so far up in the frontal sinus there. But we have good illumination of the LED light fiber on the forehead. We're going to go ahead and insert our balloon in and get our dilation done. And here we go, Dan. We're going to go ahead and inflate now. A lot of pressure, some crackling, and let's deflate. You can certainly serially dilate in the frontal recess area with any of the XprESS devices to help crush or move Agar-Nazi cells out of your way to help facilitate your entrance or entryway into the natural ostium of the frontal sinus. So I'm advancing further. So see this additional technique of advancing in further once you've done that first dilation. If you can do that, there is almost nowhere else you can be except in the frontal sinus. Whereas if you're in a small Agar-Nazi cell or a type 3 frontal cell, very atypical to be able to advance the device distally like I'm doing right now. So we're going to inflate again there, more distally. And Dan, are you doing okay with that?
Yeah.
All right, good. You look super comfortable.
I am.
Excellent. And then I'm inserting even further. We're going to dilate again. And I'll be interested to see if the light gets brighter and if the excursion gets brighter after the dilations. Okay, and deflate. And we're going to do one more inflation here proximally. And a little bit more pressure and crackling. And deflate. Okay, so I'm going to pull the balloon on the Ultra back. And we're going to go ahead and take a look here and just see. And we see some increase in excursion. I don't know if you guys can appreciate that, but again, that type 2 frontal cell is probably just blocking a little bit of the light illumination, but I feel really confident that we've got a great dilation here in this left frontal sinus. So we're going to slip that on back now. Megan's extracted the light fiber back. It's important to pull the light fiber back before you extract. It's just a lot easier and avoids kinking of the light fiber as well. So that's the frontal. And are we doing okay on time?
Yeah, I just wanted to remind the audience that there is a chat function on the website, so feel free to ask questions and we'll get to them as we can.
Yeah, absolutely. We'd love to have some questions. It makes it all that much more interesting for us. And we're going to move right along in the interest of time. We don't want to run out of time before you get to see everything. So next, you'll notice I did frontal, you know, right and then left. And now we're going to go sphenoid. And that makes sense because you go from a 78-degree bend down to about a 15-degree angle bend. So you have to do less bending and unbending if you do frontal, sphenoid, maxillary. But the cool thing about the Ultra is it's so malleable now. If you need to go to maxillary first and then go back to frontal, it's very, very easy to do it because of the 1 millimeter super sleek hypo tube. So we're going to go to sphenoid now. We've got suction hooked up, and there is a nice, I think, I can't remember the French, is it 2.4 French lumen that we can suction through. It's a pretty good sized lumen, and we can do some nice suctioning. And we almost always need to do suctioning in this sphenoethmoid recess. We're here on the left side again, and I'm displacing the middle turbinate. You can see how this suction performs. It's cleaning this little bloody mucus up really nicely. There's always kind of a coating of this cloudy mucus in the sphenoethmoid recess. So I find it's very helpful to have suction hooked up, and this suction of this brand new Ultra device is performing really well through a 1 millimeter hypo tube. So that's pretty amazing. I'm going to go ahead and advance the balloon in. I like to do a little pre-dilation in the sphenoethmoid recess before we actually do our sphenoid ostium dilation, just for access. And watch this. You'll see how our access now opens up, and I can ride the scope right in on top of the balloon like that, and boom, there's the ostium. We'll deflate the balloon, insert the ball tip into the ostium of the sphenoid sinus. I'm here at 1 centimeter. We don't need to be deeper than that. It's safer to stay more superficial in the sphenoid. Note that the superior turbinate, which Megan can point out to you right there, that superior turbinate is actually lateral to where we are. So note that the sphenoid ostium is always medial to the superior turbinate, and that's a very important safety tip for doing balloon dilation or any kind of sinus surgery in the sphenoethmoid recess. So we're going to go ahead and insert our balloon over the hypo tube into the sphenoid sinus ostium. We're going to go ahead and inflate. So a little pressure, Dan. Here we go. You might hear some crackling. Okay. And if we see purulence in this sinus, we'll go ahead and do some suctioning and irrigating and deflate. And if we don't see any purulence, we'll probably just dilate and leave it at that. And let's inflate again. So usually I'll do about 2 dilations in the sphenoid and deflate. And then we'll usually retract our balloon back out, and then we'll do a little suctioning here. And the cool thing about the device, it's so small that you have plenty of room to see around it. I mean, it takes up no room. It's amazing. And then also, we with these small scopes from stores, we're able to literally drive the telescope right in through the sphenoid ostium and have a look around. We can look and see if there's anything we need to suction, and I don't see anything. So we're just going to rely on the ventilation here to correct the sphenoid sinusitis problem. I'm going to do one more quick dilation just to make sure we're fully dilated here, okay?
So removing the LED light fiber is something you routinely do for the sphenoids?
Yes, we do. Just because we have much better suction when we have the light fiber out. And you don't really need light, of course, in the sphenoid. There's no way to transilluminate the sphenoid. So much better suction performance with the light fiber out. So how was that? Was that tough or hard, or?
That was even less discomfort than before. So.
Awesome. Okay, great job. Well, let's take a look over here on the right side. We're going to do the same thing on the right sphenoid, and certainly if the audience has any questions, we'd be really happy to take those now because we're cruising right along.
We actually do have a question from the audience. They want to know, do you usually treat the CT and the disease, or just the symptoms, or both? Or what do you look for in regards to a CT?
That is a really great question. Why don't you just flush that? That's a great question, and it's absolutely important to treat the patient's symptoms. You can have a CT scan that looks relatively normal and do a balloon dilation a week later after the CT, and there can be purulence everywhere. So you really have to take a good history, listen to what the patient is telling you. And I think you have to be smart as a clinician and understand when patients are really suffering from migraine or tension headaches. And if they have a 100% normal CT, everything is perfectly open, and they really only have a symptom of migraine, and you know that in your heart that it's migraine, that's not a great dilation candidate, because you want those patients to come back and go, wow, I'm amazingly better, okay? And so I think you have to think about what the patient's telling you and also use the CT scan as a tool, but you put both of those together. So we just flushed our suction out a little bit. It did get a slight bit of clog, and now it's suctioning really nicely again, and we're going back into the sphenoethmoid recess on the right side. Because it's a little tight here, I'm going to do that pre-dilation move. We wouldn't really have to, but I just want to show you how easy that it is. And sometimes you really need to do this pre-dilation. Let's inflate there, please. And so that's going to give us some room to ride in over top with the scope. See the superior turbinate deflate, please. Right off to the left, here's the superior turbinate. We've got everything nice and numb. I'm going to suction. You can see a little bit of blood back here at the ostium and some thick mucus that is challenging our suction, but it's actually able to get it out. It's going a little slow. And we're going to go ahead and insert now and do our dilation. We don't really need to do any more suctioning at the moment, and I'm inserting. You doing okay with that, Dan?
Yeah, great.
Awesome, awesome. Okay, here we go. We're going to dilate 12 atmospheres of pressure, hold it up for about 5 to 10 seconds to get our full dilation and remodeling of the ostium. And that's what we're doing. We're reshaping the sinus ostium or remodeling it, deflate. And this one single dilation has given us amazing dilation of the ostium there. And you know, the small lumen, a little bit challenging with real thick inspissated secretions. It is slowly pulling this through. But let's go take a look. Do we have any purulence? I don't think so. So we don't have any purulence. We don't have anything else we need to really worry about, so we don't need a lot more suctioning here anyway. Some of the other XprESS family members, the low pro and the pro, have a little bit bigger suction. So if you suction portal. So if you really want a great big suction, you'd like to do a lot of suctioning and irrigating, you certainly could choose one of those devices as well. I'm going to do one more inflation. But let me be clear, you would only open one device per case because we can do every single sinus with one balloon. You don't need to open multiple devices. Everything is self-contained, LED light fiber, suction tubing, all of it's there for you.
We actually had a question that's a little bit more about the frontal. So regarding a type 3 frontal, can you maybe comment a little bit how you would possibly work around that type 3 frontal, maybe with the confirmation methods? Or?
Well, type 3 frontal cells are very challenging. What you really need to do is study that CT scan, and you look for the pathway to the frontal sinus as it relates to the middle turbinate and the bulla location, and really study the CT, and you'll see the pathway. Usually you'll see that pathway typically just medial to the type 3 frontal cell, and you just kind of work medial to it and use your CT scan. And you can also do some serial dilations in that tract and kind of displace or crush laterally that type 3 frontal cell, and that'll get you good access. Now, type 3 frontal cells, for those of you who don't know what those are, they're great big ethmoid cells that originate at the kind of the base of the frontal sinus, and they extend way up high into the frontal sinus. So it could be very easy to get into a type 3 frontal cell, and you could feel like you're in the frontal sinus, and you think you've got pretty good illumination, but you often can't advance the light fiber distally fully, and that's a red flag that you're in that type 3 frontal cell. You also have very limited excursion in a type 3 frontal cell, so you don't see that really wide excursion. So those are important things to note. So, and if you have any question, always just go up and take a look with a 45-degree little short Storrs telescope, and you can look up there and see the frontal sinus ostium that you've dilated, see the posterior table of the frontal, and actually see even the superior recesses of the frontal to make sure you got that fully dilated. Okay, so now we're going to go to the maxillary sinus. We're going to use the Entellus Pathocyst maxillary seekers. I typically start with the 120-degree angled seeker. I don't know if you can see the angle. My finger is probably covering it up, but it's written on there, MS, maxillary sinus -120. This is a very inexpensive device, really helpful. It's got an 8-millimeter length leg there. The other end has got a 10.8 millimeter leg, right? 10.8 or 11? The leg 11. So just a little bit longer. So we typically start with I typically start with a 120-degree maxillary probe. I go in and insert it in a tip-down fashion. You'll see that the middle turbinate has displaced laterally because of our sphenoid dilation. That's no problem. We just kind of push it right back over with the seeker very gently. And then we can see some of that purulence coming out of the infundibulum there. And we're going to culture that. and I probably will irrigate the left maxillary sinus because of the visible purulence that we see. So here I am in a tip down configuration, and I'm right against the bulla here. I'm advancing the ball tip of the maxillary seeker laterally behind the uncinate process, and I'm just going to drop in like this into the natural ostium, and usually you can feel a little pop, and there we go. You can feel it just pop right into the bone of the natural ostium. So then I can reflect or pull the middle turbinate anteriorly just a little bit to aid in access with our Ultra device. Now the longer leg, you can come back in with it and basically do the same thing once you've used the short leg, and this longer leg of the device really more precisely simulates the actual length of the XprESS Ultra device. So if you'd like to know that ahead of time, you can just go ahead and probe with this as well, and you see that drops in really nicely. I love the tactile feedback as opposed to going in kind of blindly and pushing a wire in. The tactile feedback really tells you that you've gone through the natural ostium and that you're not in the posterior fontanelle, you're not in an accessory ostium. So Megan has given me a culture here, and we're going to go ahead and just swab that purulence that we're seeing here coming out of the infundibular region right there. We'll send that off for aerobic and fungal cultures and see what that shows. And if we had some resistant organism growing out, that might help us out postoperatively. We might decide to do some topically medicated saline rinses, mupirocin and saline and things like that. So we'll take that culture and see what that shows. So now we have the Ultra device, and we have it bent in a 120 degree angulation. And I'm going to go in tip down, because tip down is really anatomically the easiest way to get in most patients, just because the infundibulum from superior to inferior, runs medial to lateral. So with a tip down, you're kind of already mimicking that natural anatomy, and we drop right in, no problem. Going to advance the balloon over the hypo tube, and we'll do our inflation. Okay, and watch the uncinate process deflect. See a nice deflection there. And the intranasal portion of the balloon actually doesn't fight you. It actually helps to stabilize the uncinate process and actually helps avoid tearing of the uncinate. So the intranasal portion of the balloon, I see that as an advantage. And I'm going to go ahead now and insert just a little bit more deeply here. Dan, are you doing okay with that?
Yeah, I'm doing great.
Doing great? Awesome.
Can you maybe describe a little bit how you're inserting it more deeply?
So I'm pushing a little bit posteriorly towards the bulla and pushing towards the posterior fontanelle region. So I usually do a deflate, a single inflation, kind of what I call in a neutral position. Then the second inflation, I push in a little deeper like this and insert deeper and push toward the bulla and inflate. And then I'll go ahead on the third inflation and just pull anteriorly like this and inflate again, just to get a little bit more deflection of that uncinate process and pull it away from the bulla. Dan had some pneumatization of the ethmoids infraorbitally, which you all know as Haller cells. And so I really want to make sure we get this area nicely dilated and open to keep that tight infundibular space, which was totally occluded, by the way, on the CT. Okay, so I'm going to go ahead and slip the device back out. Another thing to note is this really nice AP distance that we have here now between the anterior-posterior distance between the uncinate process and the bulla. This is just super wide open now. You can see that space is really like a small cave. Megan's pulled the light fiber back, and now I can just usually extract the device, and really you're not touching anything anymore. See how this just swings in freely in and out? It's now like a little cave that's wide open into the maxillary sinus. So that's a really cool thing to see. I look at that as another confirming technique for the maxillary sinus as well.
Dr. Gould, you mentioned you're pulling the light fiber back. Do you want to kind of talk about maybe the new, the new stop?
Yeah, absolutely. So the Ultra has this cool feature to help avoid kinking of the light fiber. If, for example, you inadvertently pull the light fiber back too far, you're in the maxillary bend, and then you try to reinsert it through the maxillary bend, and you push really hard, and you might kink the light fiber. So there's a stop where that you Megan can demonstrate that actually. You actually pull the light fiber back, so she advanced it out, and now she's going to pull it back, and it only goes back that far, and that allows her to keep advancing it easily back and forth in the maxillary configuration. Can you just do it one more time so people can see how easy that flows? One of the great advantages of the Ultra, this brand new iteration of the XprESS device, is that the light fiber is also smaller, and so it advances through the hypotube so much more easily than some former iterations. And that's a really nice thing when you're in the maxillary sinus bend, because it can be sometimes hard to advance the light fiber. So we're going to go ahead now and go to the right side, and I'm going to go ahead and use the PathAssist Maxillary Seeker, and we're going here in a tip-down configuration. And here, because of the deviated septum, it's a little hard. The bulla is right there, and the tip-down configuration is going to be a little bit of a struggle. I can tell you I can make it work, but actually, if I flip to a tip-up configuration, which is just the terminology we use to describe how we're inserting, some defog, please. Yeah. For the tip-up configuration, I'll do the 135 probe. The 135-degree angle, if you're going in tip-up, is a little bit easier to rotate into the maxillary sinus ostium, and it's less likely to cannulate the posterior fontanelle, although I'll tell you quite frankly, the 120 and the 135-degree bend, neither are very likely to go into the posterior fontanelle, but it's just a little bit easier insertion with a 135-degree angle and a tip-up configuration. So here we are, tip-up, and I cleaned off my scope lens so you can see better. And here we are at the bulla. Here's the uncinate process. Hiatus semilunaris, we're going through and into the infundibulum, and now I'm rotating into the natural ostium. And I felt this little pop, and Dan, you probably felt that little pop, didn't you?
Yeah.
So I can tell I went through the bony ostium, not the posterior fontanelle. So again, the tactile feedback that we get from the family of XprESS devices that Entellus has created and done such a great job at, by the way, is just, it's amazing. It really is helpful. So here we are, we're going in on the right side for the last sinus that's going to be dilated, which is the right maxillary. We're in a tip-up configuration, and we're inserting behind the uncinate process. I want to show the light fiber behind the uncinate, so I'm going to have Megan advance the light fiber out just a little bit. And you can see the light fiber, let's see, pull it back some. A little bit hard to see it there. Can you do it again? You can see it. It's a little diffuse at the moment, but let me just reposition here a little bit. There we go. So there it is behind. We got a little glare. There it is. So we have a little glare, a little blood here. Sorry, give me some defog. I think I was actually abutting a Haller cell on this side a moment ago. Let's see that light fiber again, Megan. So here's your light fiber. Great confirmation of the light behind the uncinate process, and now we're rotating the device into a tip-down configuration, and we're seated within the natural ostium. So I'm going to go ahead and inflate the balloon here, and a lot of pressure, Dan, maybe a little crackling. You can see that uncinate deflection is really amazing, and the intranasal portion of the balloon, I believe, stabilizes the uncinate and helps to prevent tearing. Let's deflate. So that was that first inflation. Now I'm going to push in a little deeper towards the bulla and the posterior fontanelle and inflate again. And so that's really nice, and deflate. And again, keep the balloon up for 5 to 10 seconds to optimize the PSI, or atmospheres of pressure. Now I'm going to pull a little bit anteriorly and inflate one more time just to get a little bit of extra room in the infundibulum, and deflate. All right, so I feel really good about that. You can see this amazing uncinate deflection here, and again, this really nice AP distance that's opened up. Again, with the light fiber pulled back all the way, we should be able to see the XprESS device, the Ultra, just slip right out, no problem. Now we're in a tip-down configuration, and we're not touching anything. So we know we've gotten this wide open because before, the uncinate process was rather plastered down onto the bulla, and so that's really nicely opened. Okay. So that's it. That's all the dilations. We do have some other things to show. I don't know how we're doing on time, Jamie, but we're good. So what we were planning to do next is to demonstrate. There's a lot of interest now in mini FESS, like miniature mini FESS in the office. So we're going to do an anterior ethmoidectomy and show you how straightforward that is. We combine that in the office not infrequently if we have some opacified anterior ethmoid air cells. If you've got posterior ethmoid disease, you can also pull off an anterior and posterior ethmoidectomy very comfortably, just like the balloon dilation. So it just opens up the indications to do these cases in the office if you can handle ethmoid work. And patients absolutely love the fact that they can have their procedure in the office while they're awake, while you're talking to them. You can actually have a relationship with your patient while you're doing the procedure. So it's a really great thing for both physician and patient, I think. And the patient can be part of the experience and the process when they're just lightly sedated like this. So, okay, doing okay so far?
Yeah, I'm doing great.
Awesome. Okay, let's take a look here. So I'm going to take the pediatric straight. This is a little pediatric Blakesley forcep, and all I'm going to do is go ahead and grasp the bulla here, and I'm going to take a little bite out of it, or a little pull of it, and we're just going to pull that anterior ethmoid bulla down and open it up. And I do go ahead and usually send off this. Did you get the tissue there? Yes. It's a little more mucus coming out there that we'll need to suction. We talked about irrigating this sinus over here, and we probably will do that. So here we are, just pulling out little ethmoid air cell partitions, very simple. You can note that there's very little discomfort and very little bleeding. And you just pull these little air cells out and get that opened. So it's beautiful that you can combine mini FESS for those of you who feel that your patient needs an ethmoidectomy with all the Entellus tools, the XprESS devices that you use in the office. And of course you can do this in the operating room too, if you like the operating room environment. So here we are just pulling down some polypoid mucosal change from the ethmoid area, and that was consistent with what we saw in the CT. So we could really say we're done here. I'm going to go ahead and just show you one other maneuver. You're not used to working behind an intact uncinate process, but you leave the uncinate process intact when you're doing dilations. So it's important to me to go in and take a pediatric Blakesley 90 degree and just grab behind the uncinate process and make sure that you get these lateral bular remnants here like that. Okay, and the lateral bular remnants just helps to get everything nice and open. So normally you'd see these fragments really easily if you had the uncinate taken down, but since we're not doing that, you just have to kind of know how to work behind the intact uncinate process, and that's really the learning curve for doing ethmoidectomy either in the OR or in the office with maxillary sinus dilation. Okay, so that looks really clean, nice and healthy. I also do have a Storz shaver. This is the Unidrive shaver, and it's a great quiet device for the office. It has both the options of a pistol grip as well as the options of a pencil grip. And I have a 3mm blade on here, and I'm just going to use that to clean up a few edges in the ethmoid area. These blades, by the way, are autoclavable, which is a great thing, and it's a real cost savings for the office.
How many uses do you usually get out of a?
Oh gosh, almost too many to count. It's amazing, lots. So I'm going to suction out this with the shaver, just get all that. So look at all this purulence that's come out. This is actually coming out from the accessory ostia, but we've dilated the natural ostium above that. And I'm going to go ahead and clean up some of these little fragments here. And important, I would say important to note that in the remodel study, there were a lot of patients who had accessory ostia. And despite the fact that they had accessory ostia, they just received balloon dilation only without communicating the accessory ostia, and they did just as well as patients at 1 year in this randomized, controlled, prospective study that used the XprESS device. They did just as well as FESS patients who had that accessory ostium communicated with a wide surgical maxillary antrostomy. So we don't feel as inclined to always have to take down the accessory ostia anymore.
Actually, we got a couple of questions from the audience, if you may.
Sure.
The first one is, how often do you need to how often do you re-inject during a case? Do you do it at all?
Yeah, we like to be very cognizant of when a patient's having a little discomfort, so we're ready to inject at any point. So if I notice any white knuckling or toes curling or a little bit of like just a little bit of a wincing, I'll go ahead and say, is that uncomfortable, and we'll re-inject. So it's important to do that, keep the patient really comfortable. How was that ethmoidectomy? Was that hard or?
No, I would just describe it as just slight discomfort.
Slight discomfort.
Yeah,
Okay, so
nothing that I would describe as pain.
cool, no pain, awesome. All right, so we're going to do a little suctioning here, Dan. And Dan, is there anything you want to tell the group right now while we're suctioning?
I can almost feel like I can breathe better already.
You can almost feel like you can breathe better already.
I can feel like I can breathe better already.
You can feel like you breathe better already. All right, awesome. So very good to hear that. I can imagine why, because it looks a lot better now. And awesome, it looks really good. So why don't we go ahead, Megan, and just irrigate that left maxillary sinus quickly, and then we'll get the ethmoid work done on the contralateral side. I want to make sure everybody gets to see how nicely the Ultra device performs with regard to irrigation and suctioning, and we clearly would like to do that in this sinus that's got a lot of thick inspissated mucus. And we use the device all the time in really tight spaces for suctioning and irrigation.
So another question was from the audience, what was kind of your progression from balloon to dilation into mini-FES? Kind of elaborate on that.
Well, we just realized really quickly that patients could tolerate multi-sinus dilation so well that it seemed like a natural progression. Let's flush. A natural, can you swallow for me, Dan? It seemed like a natural progression for them to be able to tolerate ethmoid work. And I think we're getting some thick mucus out here. And so Megan is flushing with a 10 cc, 20 cc syringe, just some normal saline, and we do little pulses of irrigation. There's a little portal on the device that I have my finger over that helps to generate the suction, and you just put your finger on that, and it allows the device to suction. Megan's going to flush again. We're getting a little bit more cloudy, thick mucus out, which is awesome to see, and we're suctioning that back out. Now just swallow, Dan. Just swallow that stuff down. It's just salt water. It won't hurt you. And then let's do another big flush and irrigation. Okay, and it's coming back much clearer now. You see that? It's cleared, and Megan can note that. I think you can see that well on the screen. Just swallow for us. So we're done with that. We flushed that sinus very thoroughly till it came back clear. We've cultured it. I mean, you can really do everything, almost everything you do in the operating room in your office with the right tools. So let's go ahead now. How are we doing on time? Jamie, how are we doing on time? Keep going? Okay.
Until we finish the case.
Okay, great. All right, so here we are on the contralateral right side. I'm going to suction with a straight suction for a second, and then we'll take care of the ethmoid on this side and finish up with a turbinate reduction, and then we'll be all done. Of note, I did inject Dan's septum a little bit earlier on the right side to help with comfort. Keep that in mind. It's a very important point because you're undoubtedly going to be abutting the septum a little bit while you're working. So again, pediatric Blakesley Storrs device, again, just grasping this bulla and grabbing onto it. And I usually just grab it and pull it on down like that. And are you doing okay with that?
Yeah.
There's another question, and I'm not quite sure how you may answer this, but when you see an accessory ostia, is that something you feel the need to connect?
Well, we just talked about that. Great question. No, I don't feel like it's important to connect that. Pete's 90. I don't feel like it's important to connect that because of the remodel study that is really the first randomized prospective study that shows equivalency between FESS and XprESS Balloon Sinus Dilation at 1 year. And on the balloon dilation arm of that prospective study, no accessory ostia were connected. So no, you don't need to routinely do that. And we have really good, well-controlled data to say that. Suction, please. Okay, I'm going to go ahead and take your pediatric 45 now. So again, I'm just serially grasping anterior ethmoid air cells and just pulling them down gently and going behind the unsnate process here to get these lateral bular attachments. And then we'll finish up with the microdebrider as well on this side, and then we'll be all set. But you can see a little bit of polypoid change here, which is what we expected, which is why we chose to do the ethmoidectomy. Getting a little bit into the basal lamellar area through the posterior compartment here. And Dan, excuse me, Dan is tolerating that extremely well. And there you go. Sorry. So I'm going to now switch over to the shaver, which again is a 3mm shaver blade. We also have a 2mm autoclavable blade that we use for the turbinates, and we also have a 4mm blade if you have a lot of big polyps and really significant ethmoidal disease. So we're just using the 3mm because it's kind of the sweet spot for the office in that it's small enough to get into tight spaces but has nice debridement shaver capabilities without clogging. And that's the big advantage of this unidrive shaver, is it clogs very rarely and allows us to get done what we need to get done. And it's actually pretty quiet too, which is nice.
So a couple more questions from the audience, Dr. Gould.
Yeah.
How do you determine patients that are optimal for treatment in the office versus the OR?
Okay, so that looks really good. Hang on one second, Jamie. Almost done here, Dan, okay? Just a couple more seconds. Okay. So yeah, I really at this point do about 90% of my cases in the office, whether it's exclusive balloon dilation, multi-sinus dilation, or whether it's some sort of a hybrid type procedure. The only patients that I'm taking to the OR now are really complex, chronic eosinophilic fungal rhinosinusitis patients, and patients who have really extensive polyposis where you know you're just going to have to do all kinds of tissue removing procedures, and you'll create a lot of discomfort in that setting. So we do those under general, but really that's all we're taking to the OR these days. Most everything else is done in the office. Okay, suction please. So we're done with the frontal, sphenoid, maxillary dilations, and we're also done with the ethmoidectomy work. I'm not seeing any need for packing at this time. But certainly if you felt like you needed it, you could use Zerogel or some substance like that for the middle meatus, which helps with hemostasis. But we have so little bleeding here, I don't really feel the need for anything today. We're going to go ahead and finish up with the turbinate reduction. And what we do at the very end here, and we're almost done, we usually inject the inferior turbinates one last time with a little bit of local just to make sure it's comfortable, because the inferior turbinates wash out the local pretty quickly because of the high blood flow through the turbinates. Dan, are you doing all right?
Yeah, I'm doing great.
Doing great. Awesome.
Have you had any in-office cases that required packing because of too much bleeding? And the other question too, kind of along those terms, is, you know, what's your thought process on monitoring and that kind of thing?
Yeah, I mean, of course, with doing you know, over 1,000 cases in the office over the last couple of years, we've had some patients where we've had to use not really packing so much, but things like zero gel, Stamberger sinus foam, gel film, and things like that. But we rarely have bleeding because you're not under general anesthesia. And there's so much less bleeding when you're not under general that we rarely have to use any kind of packing. So to do the inferior turbinate reduction, I'm going to use a sickle knife and make a little tiny small puncture into the inferior turbinate, which is completely painless, right, Dan? Do you feel that at all?
Nope.
Nope. Okay. And same thing over here. We make a little tiny stab incision in the inferior turbinate. I told Dan this part was going to be completely painless, and it really is. Now I'm going to switch over to the 2mm Storz shaver blade, which is what I use for turbinates. I feel like anything larger than that for turbinates is just too big, and it results in too many little micro tears in the inferior turbinate. So really prefer the 2mm device for the turbinate reduction work. These also bleed very minimally, and you can see that we've inserted now through our site. Megan's giving me a little more defog. And all of you who are doing these, if you ever get so lucky to have someone like Megan assisting you, you'll be very lucky, and Dawn as well. So, okay, so here we go, and we're just moving this around. You can spin it. You see the little Storz sign there. You can spin that around to get any kind of directionality you want in the turbinate, and we're just kind of submucosally reducing this. I usually describe this to patients as like a miniature liposuction, which it really isn't, but it's kind of like that concept, and they usually immediately say, well, can you use it in other places for me? But it's really just for the turbinates. But it really does a great job. You can see the turbinate just shrinking right down before our eyes, and so many patients who have chronic sinusitis suffer from really substantial nasal congestion from the chronic sinonasal inflammation. And doing a turbinate reduction is rather commonplace for us to help really optimize that long-term congestion result. And I usually only reduce about the anterior 1/3 or anterior 1/2 because, as you know, the inferior turbinate is part of what makes up the internal nasal valve, which is kind of the main airflow restriction site. So we just usually feel that the anterior portion of the inferior turbinate needs to be reduced, and that's what we're doing here. We're going to stop here in just a second and be done with this turbinate because it's reducing really nicely, and you can all see that really well. Okay, so we'll just put a cottonoid on top of that, and you can see how little it bleeds, but we like to put an epinephrine cottonoid right on top of it right away, just to make sure that we don't get any bleeding for the ride home. And then that cottonoid will be pulled out before the patient leaves, but it just helps to kind of cut down on oozing for the ride home if you decongest that right at the very end. So a little bit of blood there, but no big deal. And I just kind of am compressing this laterally and holding a little pressure on it for a second and suctioning with the shaver device. And we'll just let that kind of sit there. You can rub on it a little bit just to kind of compress it. And then we'll do the same thing over on this side. And here we go.
What's kind of your philosophy on septal deviations, severe septal deviations? Is that still an office patient? Can you do those?
Yeah, we work around very deviated septums all the time, and you really have to take a good patient history and just make sure you know what the patient needs. If the patient is complaining of a unilateral fixed nasal airway obstruction that never fluctuates and that's their only complaint, they need a septoplasty. But if they really have mainly congestion issues, but their septum just happens to be deviated, if you take a good history, you'll often realize the septum is not a factor at all. So we work around deviated septums in the office, and I tell the patients, hey, we can always go back to the OR and do a septoplasty later if we need to, but let's avoid a general anesthesia if we don't need it. So yeah, that's very easy to do. And we're winding down here, almost done, Dan, with the last turbinate reduction here on this right side. And you can see this shrinking down. And note that you're not getting any tearing of the mucosa with the device, which is really nice. A little tear is not a big deal, and in fact it can help allow for a little egress of blood. And so I don't mind little tears, but you don't get a lot of mucosa getting kind of sucked into the tip of this Storrs shaver, which is really nice and performs really well. Okay, so a little bit more anteriorly to do here, just to get this anterior head. See how I'm kind of really angling, pushing on your lip a little bit there. Sorry about that, Dan.
Okay.
And we're almost done. Okay, so anterior 1/3 or anterior half of the inferior turbinate submucosally resected and looking good. And we're just going to put a cottonoid on top of that. Again, we're not going to use any packing material today. We're just going to let everything stay open, and Dan will be back to normal activity tomorrow. He'll be able to blow his nose gently starting tomorrow. Excuse me, back to normal activity tomorrow, and really whatever he wants to do. So instead of having a full-on fest in the operating room and having 5 to 7 days of recovery, lots of narcotic pain usage, lots of prolonged crusting for weeks, and multiple postoperative debridements, the XprESS family of tools has allowed us to move this procedure into the office and actually just totally transform the patient treatment experience. So it's been a really moving and monumental thing for all of us. Alrighty. So we're all done. Are there any more questions at all that have come through that we could answer? It might be nice to have Dan sit up and tell us a little bit about what he thought. How about that, Jamie? What do you think?
Absolutely.
And for that, would you want the lights on or off? Or? All right, I'm going to take this off. Great job. Awesome.
You too.
Really, really good. So not bad?
Yeah, feel fine.
Awesome. You look good.
Thanks.
So I'm going to actually go ahead and untape these and we'll tilt you up here in just a second, okay? Okay, so I'm going to tilt you back up here and take a second to get you back up there. All right. And keep your, let's keep your head back just a little bit like that, just so you don't get any dripping of blood on your nice shirt there. And I'm actually going to tilt you back just a little bit to help facilitate that. Okay, so anyway, you did it. It was very simple. You impressed us all with how well you kind of hung out there and relaxed. What were your thoughts about the procedure?
Throughout the whole procedure, I wouldn't say I experienced anything that I would describe as pain, just slight discomfort. And already I feel like I can breathe better.
Awesome.
So,
That's
yeah,
good.
Yeah, very, very happy.
Good, 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 good. Not much bleeding, and you were comfortable during the procedure. Did you feel like the oral sedative part was beneficial?
Yes, just the right amount. I never felt woozy or nauseous, just the right amount.
Yeah, and Dan had quite a bit of oral sedative, and you can see how well he's articulating. He's not overly sedated, but he had about 3 tablets of each of Vicodin and Valium. So he had quite a bit of oral sedation, but he's doing great, looks good, mild sedatives, really safe to use, and so good job.
You too, thanks.
Yeah, good job. Anything else? Any other questions that have come in, or do we have any more time? Or
I think that is. I think that's a wrap. We don't really have any questions. So great job, Dr. Gould.
Hey, thank you all for joining us, and thanks to our team, and thanks Entellus for putting all this together. It was a lot of work. These guys did a great job, and thanks to Dan, for doing it
Thank
for
you.
us. All right, good job.
Too.
All right.
Thanks, everybody.